a large number of patients with MDS will need blood transfusions. Anemia is the most common reason for, or the most common symptom and manifestation of MDS. If you look at all MDS patients, more than 80% will require blood transfusions, and data suggests that more than 40% will require frequent blood transfusions, or what we call transfusion dependence. So many patients will require blood transfusions, and for platelet transfusions, the estimates vary, but especially patients with high risk MDS, when their platelet count is quite low, they often also need blood transfusions. So those are some of the reasons that will bring the patients to the clinic frequently, in addition to the hypomethylating agents that require intravenous administration or subcutaneous administration. Also, the need for transfusions are the two most common reasons why patients have to come frequently to the clinics.
When I see a patient with newly diagnosed MDS, some are already transfusion dependent. They've needed red blood cells and they've needed platelets. If they are of good health and they are of intermediate or higher risk disease, and they are interested in receiving treatment, we would sometimes consider hypomethylating therapy for them. Now, not all patients with higher risk disease are transfusion dependent. And so one of the interesting aspects of hypomethylating agents in general is that patients can feel worse before they start to feel better. And what we find is that patients who receive hypomethylating therapy, both azacitidine and decitabine, generally have their counts worsen during the first 2 cycles. So it's important to be upfront and honest about patients with that, so that you don't lose their confidence in you. And it's important also that you have adherence to compliance. So on average, the median time to response to azacitidine is about 4 months, and the median time to response to decitabine is about 2 months. For azacitidine, the majority of patients who do respond by 6 cycles, which would be 6 months. And for decitabine, the majority of patients who respond by 4 cycles, which would be 4 months. So if patients stop early, many patients haven't received enough therapy to get a clinical benefit. And it is expected that the counts would get worse. And so if they're not transfusion dependent, they could become transfusion dependent. And if they are transfusion dependent, their transfusion dependence could worsen. But I really try to encourage patients to complete a full duration of therapy with either the azacitidine or decitabine before we say that it doesn't work. And one of the biggest issues with both of these agents is that the drug is stopped too soon.